Let's start with the first session. We will discuss the importance of lesion preparation and assessment of final results. And it's a great pleasure for me to co-moderate this session with my colleague, Dr. Adam Castrati. And we have a great panel of experts, Dr. Fernando Navarro y Felipe Navarro, perdón, y Dr. Pablo Avanzas. So, Dr. Castrati, if you can say something.
Thank you, Anna. It's a great pleasure for me to be here. It's not the first time, but I needed now 4 years to come back to Madrid. And for me, Madrid is the best place to organize such a meeting due to the huge experience of Fernando Alfonso in this field. I'm happy to be here.
Okay, this meeting is an interactive meeting, so please feel free to participate. And I think we have some questions for the... Okay. If you can see the questions. Okay.
Oh. It's here also.
Okay, first question. In what percentage of your PCIs do you use drug coating balloons? Let's go through the panel. Felipe, Pablo?
Well, in my hospital, I would say that we use DVC in less than 10% of the patients, mainly in small vessels, bifurcations.
Okay.
I would say from 10 to 30% in my hospital.
30%?
From
10%. Okay, it's changing. This is live because okay, 3 to 10% in our audience. Okay, perfect.
So we are between 10 and 20% of the cases so far, but it has been increasing also in our center.
Okay, next question. Quick questions because we have 5 minutes. The main reason for not using DCB more frequently in your practice is lack of experience or uncertainty to the acute results, not time, or lack of scientific evidence. Difficult question.
I will say in my case that is mainly because of lack of evidence in many type of PTCIs.
Okay. Most of you uncertainty of the acute results. Okay, that's important. Pablo, what's your opinion?
We use it quite a lot, but I would say the main reason for not using more maybe also the uncertainty on the acute results, maybe. Yeah.
For me, the same. And lack of scientific evidence is important too, I think. And Dr. Castrati?
The proportion of the use of DCB is under 20% because we have restricted the use for a long time to the in-stent restenosis patients. And this is, but we are expanding now also to de novo lesions. That's why we are increasing also.
Yeah. Okay. And I think we have one more question. 50% uncertainty. Okay, it's okay. 2 questions. Well, the chief, Dr. Fernando Alfonso, said that we can start. So we have 6 excellent talks. And if you agree, we discuss at the end of the session. Perfect. So it's my pleasure to introduce you Dr. Jäger. I don't know if, okay, perfect. Presenting from lesion selection to preparation and final optimization. Thank you so much, Dr. Jäger.
Good morning, everybody. Thank you for the introduction. Fernando, thank you very much for inviting me here in this very nice and prestigious meeting. I really like Spain, I like Madrid, and it's really a pleasure to be here. My task in this session is to speak about the importance of the lesion selection in lesion preparation, how to prepare and how to finally optimize this. I want to start with this picture here. This is a large analysis of more than 10,000 patients, and it's showing you the main factors why stents are failing. Stents are the mainstay of PCI therapy nowadays, and it's an easy fix of coronary lesions. You don't have to think about a lot, you just put in the stents. Nowadays a little bit post-dilatation, but then it's done. But you know that stents, they have Achilles heels, and lots of lesions, they are not made for treatment with drug-eluting stents. And here in this analysis that shows really nicely that the predictors of restenosis were small vessel size, increased stented length, complex lesion morphology, diabetes mellitus, and prior bypass surgery, which is a sign of complex coronary anatomy. So we see that here there is a problem, and now I want to offer you some lesions that you could tackle with DCB, some lesion and some patients. There's on one side lesion characteristics. Nowadays the main indication for drug-coated balloons are in-stent restenosis in many cath labs, but there are some other good indications such as small vessels, bifurcations, long lesions, and diffuse disease. But there are also some patient characteristics. You can use the DCBs in a very elegant way. These are the patients with diabetes mellitus, acute coronary syndromes, and high bleeding risk to reduce the duration of dual antiplatelet therapy. But having said that, you just can't think about DCB use in all lesions because it's not exclusive for all these lesion and patient characteristics. DCBs can be used in every lesion. As far as I know or I'm concerned, I try always to prepare a lesion in order to achieve a good result, and if the result is not good, then I switch to stents. So I want to discuss with you all these lesion and patient characteristics. As I told you, the most frequent indication for drug-coated balloons are in-stent restenosis. Here is a large meta-analysis of this that shows that drug-coated balloons are very efficacious in these lesions, but also very safe. The efficacy is not that good as with drug-eluting stents, showed on the left side, but the safety is very high, and therefore is a 1A indication for in-stent restenosis. Another good indication, as we heard, are small vessels. In this indication, we could show in a randomized trial against drug-eluting stent that primary endpoint comprised of cardiac death, myocardial infarction, target vessel revascularization is non-inferior to drug-eluting stents, and therefore this is a really good indication and can be used in many patients. Another good indication is bifurcations. You can use drug-coated balloons in the main vessel or what I do mostly in the side branch to get a good result. Here you see the PEPGAD-BIF trial that proved that an intervention in the side branch with drug-coated balloons offers you a much better angiographic result, and I think also a much better clinical result. Other indications that are quite novel are long lesions, are chronic total occlusions, are diffuse disease. These are these patients where you never know when to stop implanting drug-eluting stents. And I have a really good experience with drug-coated balloons in these patients. What you can do is a hybrid therapy with spot stenting where there are some dissections, and to treat the rest of the vessel with drug-coated balloons. This is something that has been shown in this study here from South Korea, that you have a really good angiographic result. However, their clinical data here are missing. Another study from South Korea is this study here that showed that you easily can combine drug-coated balloon with drug-eluting stents in multivessel disease. The aim of this approach is to reduce the burden of drug-eluting stents, to reduce the metallic implants in the coronary arteries, and with that you see here a very nice result. And regarding patient characteristics, you see here diabetes mellitus as a good indication. This is a subgroup analysis from the Basket Small 2 trial, where we could show that drug-coated balloons, they offer here a real good alternative to drug-eluting stents in small vessels of diabetic patients. Another really good indication for drug-coated balloons may be acute coronary syndromes. Acute coronary syndromes are very frequent. Mainly non-STEMIs are very frequent, and often the lesions are not thrombotically occluded, and therefore the drug-coated balloons may offer here a really good alternative to drug-eluting stents, as shown by Bruno Scheller in his PEPGAD non-STEMI trial. He compared drug-coated balloons against bare metal stents and drug-eluting stents half and half, and he could show that drug-coated balloons, they have a really good MACE rate, even better than drug-eluting stents after 9 months. And finally, the high bleeding risk. Thomas Rizan, who is sitting here, has been shown in his debut trial that the reduction of dual antiplatelet therapy that is possible with drug-coated balloons is really a clinical advantage. You can really shorten the dual antiplatelet therapy to 4 weeks or even less, and therefore the occurrence of bleeding events is much less frequent in these patients. That has been shown in this trial. The comparison were bare metal stents, but the safety was really high. There were no problems regarding thrombosis or thrombosed vessels. Now we discussed the lesions and the patient's characteristics. I don't want to go too deep into the preparation and final optimization of the vessels, because we will hear that in the remainder of the talks here. I just want to say, to tell you that what we discussed and published in this consensus paper 3 years ago is that we want to achieve a good or acceptable result. It doesn't have to be stent-like, but it has to be good. There shouldn't be any flow-limiting dissections, there shouldn't be high-grade stenosis, and there should be an FFR of more than 0.8. But if you have that, you can use a drug-coated balloon. And how do you achieve that? With standard and specialist balloons, you should aim for a balloon-to-vessel ratio of 1:1, and you also can use other techniques such as rotablation and lithotripsy to achieve these results. You also can use functional measurements or intravascular imaging if needed, but the aim should be a good angiographic or acceptable angiographic result. And therefore, I finish my talk here. I tried to show you that stent failures occurs in many anatomical and clinical situations, and there are some lesions and patient characteristics that have really favorable results with drug-coated balloons. I told you about in-stent restenosis, small vessel disease, bifurcations, long and diffuse lesions, and I also told you about patients with diabetes mellitus, acute coronary syndromes, and high bleeding risk. However, you can try to achieve a DCB-only approach. You should at least plan it, and if it fails, you still can use the stents. I showed you that the lesion preparation is the key element here, and you have different tools such as the standard balloons, the specialist balloons, and other methods such as rotablation or lithotripsy. And the functional measurements can be a big help, intravascular imaging as well, and therefore I stop here and give the word back to the chairs.
Thank you so much, Dr. Jäger, for your great presentation. And I would like to invite Dr. Castrati to talk to when and how to use the scoring and cutting balloons before drug coating balloons. Thank you.
Thank you, Annabelle. So I have shown here two typical examples of cutting and scoring balloons. One with the blades here, you see, and one with the wires, and it can be nitinol wires or nylon wires. I looked for the niche of the use of cutting and scoring balloons, and I couldn't find a better figure, simpler figure than that of Antonio Colombo, which is typical for him, where both cutting balloon and scoring balloon are advised in this kind of lesions: in-central stenosis, calcified lesions, calcific nodules, fibrotic lesions, and stent underexpansions. But I have highlighted here in-central stenosis and calcified lesions due to the frequency of these situations and also to the bigger success rate with these devices. Let's start with in-central stenosis. And here I have shown one example with in-central stenosis. This is before OCT images here, showing the neointima in both views here. And we have also after the use of scoring balloons, and what you see here is that the scoring balloon achieves what is intended to achieve. That means that the neointima is cracked here, and this is not only a mechanical advantage, but also for the drug-coated balloon is an advantage because it increases the depot of the drug, it increases the penetration of the drug to the neointima. With this premises in mind, we started Desire 4, which is randomized trials comparing paclitaxel-eluting balloon alone, and we have used the Pantera Lux in this study against the combination of scoring balloon as lesion preparation with, after that, with paclitaxel-eluting balloon. Sure, we used the Pantera Lux because the company was able to also to fund the study. There was no preference in this case. This is the design of the study. You see that it's a broad inclusion criteria and very narrow exclusion criteria study. So we excluded only lesions in the left main, and acute STEMI patients were also excluded, and cardiogenic shock. All the rest of in-central stenosis patients were included in this study. 252 patients with drug-eluting stent restenosis enrolled during this 2-year period, and you see the distribution. Half of them were assigned to scoring balloon and high plus coated balloon, and half of them to only coated balloon. The primary endpoint was diameter stenosis at follow-up angiography, and here you see the difference. It's not a big difference, a 5% difference in the diameter stenosis at follow-up, but which reached the statistical significance. If you look at the other endpoints, we had a significant difference in the binary restenosis, angiographic restenosis, 32% in the control, in the DCB alone group, and 18.5% in the combination scoring balloon plus DCB. Target lesion vascularization, numerically, there was an advantage with the scoring balloon, but we didn't expect also big differences here, statistical significance here, due to the limited number of patients, and the trial was not powered for clinical endpoints. Now the other niche was calcified lesions, and just to show that even in calcified lesions, it is shown here with the OCT, the scoring balloon is able to crack the calcified lesion. There are several randomized clinical trials of cutting scoring balloon combined with drug-eluting stents, and I start here with COPS from Antonio Colombo. COPS is a small trial with 100 patients, but it was able to show in these patients who got at the end also drug-eluting stents that scoring balloon against non-compliant balloon was associated with larger, minimal lumen area, stent lumen area, than the non-compliant balloon. And also on the other side, eccentricity was also better for the combination of scoring balloon plus drug-eluting stent as compared to non-compliant balloon. The other trial is ESAR-CALC trial from our center, which included about 74 patients. And here we compared the scoring balloon with the OPN balloon in patients with calcified lesions. And you see the primary endpoint was stent expansion index was numerically better for the OPN balloon as compared to scoring balloon, but was not a significant difference here. On the other side, we saw that the diameter stenosis and minimal lumen diameter in patients who were assigned to the OPN balloon, to the super high pressure balloon, were better than as compared to the scoring balloon. The other study performed also in Germany, PREPARE-CALC, compared rotablation with the scoring balloon. What it showed was a higher strategy success with rotablation as compared to the scoring balloon. No surprise for that, a 17% difference in favor of the rotablation. But what was even more important were the recently shown results in the German Congress of Cardiology. And you see here the target lesion vascularization was very low for patients assigned to rotablation as compared to those assigned to scoring balloon. But I have to say again, these are all trials that at the end, all patients got drug-eluting stents, not DCB. We pulled together the data from ESAR-CALC and PREPARE-CALC to see what is the role of 3 different strategies: rotational atherectomy, modified balloon, scoring balloon, and super high pressure balloon here. And you see for the stent expansion, there were no significant differences between these 3 strategies. The maximal stent eccentricity was better for the super high pressure balloon, and the strategy success was better for rotablation as compared to the other 2 strategies. But I have also to advise that do as much as you can before stent implantation, not wait for the stent implantation. This is also supported by this conclusion here from the group of Takeshi Kimura. Implanted stents significantly increase the difficulty of balloon dilatation, and adequate pretreatment is critical for successful coronary stenting. Now, cutting and scoring balloons in combination with DCB in de novo lesions. Here is the observational study, the password study, which included 481 patients, but I have to say the number of calcified lesions was limited. Only 33%, 1/3 of the patients had calcified lesions. No comparison in this. This is only one arm observational study. And they compared just the target lesion failure between calcified and non-calcified lesions in these combinations of cutting balloon plus DCB. And you see that calcified lesions, I don't take it for very important here because it's not a randomized comparison, but calcified lesions had a very good rate in target lesion failure. Conclusions: cutting, scoring balloons are a valuable specialty technology. One randomized trial has confirmed the value in combination with DCB for in-stent restenosis. Randomized trials are needed to assess the specific value of cutting, scoring balloons in combination with DCB in de novo, particularly calcified lesions. We can be skeptical about the role of cutting, scoring balloon, but we are happy to have this fact in Germany. The insurance companies are very enthusiastic about their use, and that's why we make a profit of 650 euro if we use the scoring balloon in patients with percutaneous coronary intervention. Thank you very much.
Thank you. Thank you for a great talk. Thank you. And then Dr. Bernardo Cortese is going to talk to us and to answer a key question. effects. When should we be concerned on residual dissections after drug-coating balloons? So, Dr. Cortese, thank you.
Yes, thank you, thank you. Yes, it's a key question. We had a long discussion with Adnan yesterday regarding the fear that you used to have when you left dissection after POBA. So this is why I went through the literature and I found this nice paper, and Antonio is here, he's a co-author. I don't know if you remember having published also this a few years ago. This paper is aimed at investigating the fate of the dissections left after POBA. It was the 90s. There were some stents, obviously, so here not all dissections were left, so flow-limiting dissections were stented, and the fate of dissections rechecked during angiographic follow-up was that after 6 months, 37% of the cases were still there. There was still a dissection with a quite high number of binary restenosis at that time. For sure, we know that leaving a dissection proximal to a stent is not a good thing. In fact, if we observe it with the angiography, but also there are some new parameters by OCT and also from IVUS that are showing that you should, in many cases, implant further stenting after leaving distally mostly the dissection, because anyhow it is correlated with an impaired clinical outcome if you leave it. Then came the DCBs. We have learned mostly from the periphery that leaving a dissection after a DCB, for example an SFA, if the dissection is not flow limiting, was associated with 0 cases or very rarely cases of occlusion and with the total healing of the lesion. And it is something that we have already shown and understood quite clearly also in the coronary arena. Okay, so we have some nice parameters. I will go through them in deeper during this presentation, that if you leave a dissection after a DCB angioplasty and the flow is good, it's going to heal during the angiographic follow-up. So you don't need to do angiographic follow-up to all of the dissection that you leave after DCB. One of the reasons why DCBs, at least the paclitaxel DCB, are all so effective is probably the lumen enlargement that we have seen with some paclitaxel coated balloons, at least with the good ones, which are showing in around 2/3 of the cases an increase in the lumen size as compared to the final diameter that you leave after DCB PCI. But you have also to remind that after POBA we also have some lumen enlargement, but it happens in between 5 to 10% of the cases, not 70% like for paclitaxel. Which is the correlation between lumen enlargement and dissection? Probably this study from Yamamoto is telling us something more. They investigated, thanks to IVUS, what they called the dissection index and how it was correlated. And it was directly correlated with the effect of lumen enlargement of paclitaxel coated balloon quite nicely in terms of enlargement of the vessel wall. So the conclusion by these investigators was that the more you dissect, the better is after drug-coated balloons if you want to have an effective lumen enlargement by means of paclitaxel. But the main question is it safe to leave a dissection after DCB if you are not an experienced DCB operator? We have tried to respond to these questions a few years ago. We left 48 dissections without any stenting, type A, B, and some type C, and we checked them all after 6 months. And we have seen on the right part of this panel that in the vast majority of the cases, in 45 cases out of 48, the dissections did heal. And interesting, we had 3 cases of chronicized dissections, but we had 0 cases of abrupt vessel occlusion in this consecutive series of patients with DCB. And the outcome, obviously, the paper enrolled only 150 patients. The outcome was very similar, but there was no increase in MI, no increase in TLR in the dissection patients. Then we have some data also with sirolimus coated balloons, which are coming out recently in the last 5 years. This is, I will present some more data about this study in my next presentation. It's the largest study ever done on DCB. It's a prospective registry, an independent one. Primary endpoint is TLR. And we have recently presented a 2-year follow-up, but as I said, I will go through this paper and these results later. We have a sub-analysis of Eastbourne of those patients that were left with a dissection after Magic Touch sirolimus coated balloon, because we wanted to understand if the safety that we have seen with paclitaxel is there also with this sirolimus coated balloon. So we record data for 73 patients which were left with type A, B, and a few of them also with type C, good flow dissection. I have to remind you that 7.8% of the cases of the patients enrolled into Eastbourne were treated with a bailout stenting for flow-limiting dissection or for recoil, but in this case it's not. So we wanted to understand which was the fate of this dissection after sirolimus. And what we saw was that only in few cases type C dissections were left, and this is what we should do, like Raban already told us in his previous presentation. There are no major differences between the two populations, the de novo population of Eastbourne and the dissection cohort. You can see that in the dissection cohort, lesion length is higher, and the predilatation was always done, differently from the other cohort of patients where predilatation was done only. But not sufficiently, I would say, in 91% of the cases. This is the clinical outcome. Also here it is reassuring because there is no differences at 1 year in terms of clinical endpoints. And importantly, we have 0 cases of MI in the dissection cohort, and TLR is very low in this native vessel disease population. So also with this device, the dissection doesn't seem to be a big problem. And now, yeah, I have 3 minutes. I will finish with this case. It's a quite complex CTO. It took a lot of time to cross the lesion. We had to use guide extension, obviously microcatheter, but the balloons didn't cross. So we used some atherectomy there with a 1.5 bore, and then we started predilating the vessel wall, the vessel, the LED. You can see also from the balloon predilatation how it was difficult to manage this highly calcific lesion despite the use of rotational atherectomy. And then we delivered some drugs in the end. We didn't want to put metal in this highly complex and very long diffuse disease in the LAD. We used a blended therapy of sirolimus and paclitaxel in this case, and this was the final result, which was not stent-like. There was a diffuse dissection, mostly in the mid and distal part of the LAD, and the patient came back after a few months with a stable angina. But his problem, he had the problem for instant restenosis on the RCA, but the LAD was still good, with some minor recoil proximally where there was that bending of the balloon, which was not significant either from the angiographic point of view, but we wanted also to have some adjuvants from the physiology. So we are gathering more and more information regarding the clinical outcome of leaving dissection after DCB. There are other papers also coming out. 2 of them are from China. My conclusions: leaving a dissection after stenting, either proximally or distally, is something that you should fix with another stent, at least if the dissection is visible at the angiography or if it protrudes into the media with intravascular imaging. There is plenty of data that leaving a dissection after drug-coated balloon is safe. In the case of paclitaxel, we have seen how it is associated with improved angiographic parameters. We have no data for sirolimus so far in terms of late lumen enlargement correlated with a dissection. Only types A and B dissection with good T-3 flow, I want to underline this, should be left after DCB. And in case of bailout stenting, please use only short drug-eluting stent. Thank you.
Thank you, Dr. Cortese, for your excellent presentation. We discussed at the end. Okay. And now it's my pleasure to introduce you, Dr. Nieves Gonzalo, who is going to talk to us about OCT to guide and optimize final results after drug coating balloon. Thank you, Nieves.
So good morning, and thank you, Fernando, for the invitation. I'm going to divide the talk in two parts, because I think they are two very different entities, rare stenosis and de novo lesions. And let's start with de novo lesions, where probably we have less evidence, or definitely we have less evidence with DCBs, but these are probably the most frequent indications, apart from the others that have been described, but small vessels, diffuse disease, or bifurcation. And how can we use imaging when we decide we're going to treat a lesion with DCB? Well, if we use OCT, specifically pre-intervention with drug-coating balloons, this is going to give us information about the plaque distribution, and this is very important in bifurcations, which is one of the main indications probably of DCBs. Also about the vessel size, and again, this is very important to understand which type of balloon do we need to use to ensure that there is an adequate contact with the vessel wall, etc. And there is also some interesting data coming from the information we can get from the plaque type. There are many factors that influence local drug delivery and how the drug is going to affect the plaque that we're treating. Some of them are related with plaque characteristics and also with the vessel response to the device. And you can see here that the type of plaque is not the same if you're treating a calcific plaque or a lipidic plaque or a fibrous plaque in terms of how the drug is going to be taken, let's say, by the plaque. And also, for example, if you have hemorrhage or neovascularization. These are all parameters that can be assessed with imaging. So we know, for example, that fibrous lesions are a type of plaques that will favor, let's say, the uptake of the drug. However, if you have calcium can decrease the uptake of the drug, but could also trap the drug and create some areas of extreme concentration of the drug. While in lipidic plaque, the uptake of the drug is generally decreased. So is this information important? This is probably the next step to understand if the type of plaque can influence the effect of the balloon. And I don't think there are any studies still evaluating that. Hemorrhage or neovascularization, as the ones you can see in this OCT image, can also increase permeation and promote the transport of the drug and then increase the uptake of the drug. So I think this is an interesting concept. The type of plaque can influence how the vessel is going to take the drug, and probably this is also different from different drugs and also from different balloons with different recipients, really a complex interaction of all the things that influence how the drug is going to, in the end, have an effect on the plaque. Also, the device-induced dissections, for example, on the vessel can influence how the drug is going to be taken, or if we generate, for example, formation of thrombus, this is also something that can influence the effect of the drug. And again, dissections or thrombus is something that we can assess with OCT. About calcific plaques, there have been already some talks about calcific plaques. Of course, it's an interesting field because you could have the potential to avoid stent expansion. That is something that can happen in these lesions, and also the delayed strut synthetization that happens frequently in this type of plaques. As I said, drug uptake can be decreased, but also sometimes increased in calcium. There are some small series suggesting that you can have good results using, for example, rotational atherectomy plus DCB strategy. It was very interesting, the images that Dr. Castrati showed about how with scoring balloons sometimes you generate cracks. You all know the cracks we generate in calcium, for example, with lithotripsy. So is this something that applies only if you do atherectomy and, let's say, decrease the calcium burden, or can be done also generating cracks that can facilitate the drug take by the vessel? I mean, this is all very interesting and something for the future. Apart from understanding the type of plaque, etc., this is something a bit more theoretical. Of course, what imaging can do and can help you to do is understand if you have achieved a good result before using the DCB. I saw in the question before that most people was not using DCBs because you are not really happy generally with the acute result and you decide in the end to implant a stent. Well, imaging can be very useful for this, and I think we probably need to all learn again how to do proper balloon angioplasty, but OCT can be helpful in this, can give information about the luminal gain, if you have achieved a good lumen. if you have residual stenosis or you have significant dissections. We have seen from Dr. Cortese how to identify these dissections from the angiographic point of view. I think OCT can reassure you sometimes to let some dissections, for example, when they don't extend to the media or when they don't extend circumferentially in the arc. And there's also this interesting, is anecdotic, let's say, but it's interesting, no? That sometimes you can even see how you're applying the drug with, in this case, with IBUS. And you can see how the plaquette accel after the application of the balloon can be seen, actually, in these IBUS images. So, can this have any application to understand whether the drug has been properly applied or we have left some segments without treatment, etc.? Well, again, this is something probably for the future. About restenosis, I think we have much more evidence. And again, we can use it for the pre-intervention to understand the type of restenosis and also before the DCB application. And imaging is key in restenosis, and I think it's the main indication, or actually the indication that that we can't do a restenosis nowadays, I think, without imaging. It's not good practice, because first we can understand how what is the mechanism and how to treat this, and also the tissue type of the restenosis. And I think this is important for the DCB treatment. So about the mechanism, we can understand if we have neointimal proliferation, stent under expansion, if there is a problem of plaque progression at the edges, or other mechanisms less frequent, such as a stent fracture or gaps. But as I said, with OCT, you can also understand which type of restenosis, restenotic tissue you have inside the stent. And this is very important. Does this help you to understand how to treat this lesion? Well, we have some data coming from this pooled analysis indicating that if you have an homogeneous restenotic tissue, the one we used to see, for example, in the era of bare metal stents, these lesions, you don't have difference if you use a drug-coated balloon or a drug-eluting stent. So this is really the type of restenosis that is perfect, actually, for DCB. If you have a non-homogeneous restenotic tissue, or heterogeneous, or can be layered, can be neoatherosclerosis, probably here we are including all these type of tissues, then here it looks like there is an advantage from DES. Again, this is another study indicating that the type of tissue you have inside the stent has an impact on prognosis, and you can see that actually homogeneous is the best type of tissue you can find, is the one with better prognosis. Well, if you have heterogeneous tissue, these patients, they have more events. And again, having this heterogeneous restenotic pattern is related with more recurrent restenosis at follow-up. So, as I said, intracoronary imaging can identify the mechanism and guide your treatment in restenosis. So if you have stent under expansion, of course, the objective would be to expand the stent with balloon dilatations, lithotripsy, whatever you need. And then maybe after that, probably the only thing you need is DCB. If you have proliferation, neointimal proliferation that is homogeneous, this, as I said, can be treated either with DS or DEP, and here they look like equivalent. Each progression, if the plaque has progressed, probably you will need a new stent. And the big questions, of course, is neoatherosclerosis, because this is actually the type of restenosis that we are finding more and more frequently, because now the patients, the all bare metal stents, when we find them, is all neoatherosclerosis, and the DES very frequently, either it is under expansion or it is neoatherosclerosis that can develop earlier, as you know. So the big question is, can we treat neoatherosclerosis with DCB? And OCT, of course, is the key to identifying neoatherosclerosis. Can we treat it with DCB? Well, there is some data indicating that it can be treated with DCB, and actually there are no differences in patients treated with DCB, neoatherosclerosis or non-neoatherosclerosis in this small group. We also did an analysis of the RIFS 4 and 5 studies in the OCT subgroups, and it looked again like there were no significant differences between the patients with or without neoatherosclerosis in the plaquette accel-coated balloon group. These are, however, small studies and more evidence is required. But again, neoatherosclerosis, is this an homogeneous entity? We know it's not. You can have calcific neoatherosclerosis, like the one you see there, or you can have lipidic neoatherosclerosis, like the example on the bottom, and clearly these are very different. So again, including neoatherosclerosis only in one group doesn't look like the best strategy, and probably these two entities require different treatment. Just to show you an example, this is a patient that came with in-stent restenosis. He had 2 stents that have been previously implanted in another center, and now he comes with a non-STEMI. You can see this very tight restenosis. And if we have a look at OCT, you can have a look at the pullback here, and then we will stop at certain points. But you will see, or you are seeing already, that there are 2 problems. First, you see that there is a lot of calcium in between the stents. So the patient probably had a restenosis that was related with calcific neotherosclerosis. The treatment was implanting another stent, and you can see that now he has this calcium sandwich. So he has a lot of calcium between 2 layers of a stent, and I can tell you this is really difficult to treat. So again, calcific neotherosclerosis, probably not a good idea implanting a second stent if you find calcium inside the stent. So this is pre-intervention and how to assess the type of tissue and how to guide your treatment based on that. But of course, again, you need to make sure that before you apply your drug with your DCB, you have an optimal result. And this means you have an appropriate stent expansion, you have achieved good luminal gain, you don't have significant dissections, and you don't have significant residual stenosis. And this is very important, and using imaging in this context just before applying DCB, understanding that your result is optimal is important, because, for example, you know, if you let a stent that is underexpanded, this will be a predictor of recurrent restenosis. And again, as before I showed you, there are some anecdotal, let's say, cases, but interesting, indicating that you can actually kind of see how you apply the drug. This is actually from Armando's hospital with the, you can see in this restenosis of a bioabsorbable scaffold, how you can see, let's say, the plaquetic cell on the vessel wall with OCT. And again, can this have any clinical use? We don't know. But just to finish, I'm going to show you an example of how you can really use imaging to guide your treatment in patients with restenosis or with de novo lesions that you are going to treat with DCBs. This is a 75-year-old male. He had a previous PCI to the LAD in 2004, and now he presented with stable angina. You can see that he had this very significant lesion in the LAD, involving also the left main. So there is this kind of moderate lesion in the left main, also lesion in the proximal LAD, but it's all very significant from the physiological point of view. And I'm going to show you this OCT run, and you will see that actually the restenosis is caused by neotherosclerosis, and you will immediately see that there are different areas where here it looks a bit more lipidic, here is more homogeneous, but here we start to have a lot of calcium, and you can actually see that there is a ring of calcium inside the stent, and this extends to the proximal edge. So it's probably progression of the plaque at the edge, but this calcium is entering the proximal area of the stent. And then in the left main, he had this calcified nodule, and he had a more severe stenosis when we approach the proximal. This is the left main, and at the distal level, so severe stenosis also of the left main. But what is interesting is that in the same patient you can find very different types of morphologies and tissues inside the restenosis. You can see, for example, here, again, more macrophages or lipid. You have areas more homogeneous, as we saw. You have areas of calcific neotherosclerosis with even rings of calcium inside the stent, like the one you see here. And if we go to the left main, this is the proximal segment of the stent, so the edge of the stent, a calcified nodule, and in the left main again, a lot of calcium, but in this case, a bit more concentric. So in this case, we decided to treat everything with shockwave to start, because there was a lot of calcium. So we treated with a shockwave balloon both the LAD and the left main. And after that, this is the result. I'm going to show you here the OCT result, and you will see that actually it looks better. We have achieved lumen enlargement, and we have created fractures, as you can see there, in different points in the calcium. This is the proximal part outside the stent. Again, you can see these disruptions of the calcium at different levels. You can see actually that the nodule is more protruding now because it's kind of disconnected from the wall because of the fractures we have generated. These are two still images just to, again, emphasize how you are able to break the calcium inside the stent. And now is the moment to decide, so what do we do with this patient? Do we implant another stent covering all the restenosis, or do we treat different segments with different devices? Well, in this case, we decided to treat the area of calcific atherosclerosis with DCB, because we don't want another layer of a stent jailing this calcium between struts. And then we implanted a stent in the left main, because we thought it was necessary to have some kind of a scaffold, especially because there was this calcified nodule that was protruding a lot after treatment with IVL. And this is the final result. You can see the circuit is a bit pinched, but it was negative physiology. And this is the final OCT, where you can see how we have an area that has been treated with DCB, and you will see that actually the result is very similar to what you saw before. And then we have this area where we implanted the stent in this de novo or progressive lesion in the proximal LAD and left main. But really, in these kind of cases, you can guide your strategy and treat different regions with different devices, DCB or stent, using your imaging findings. So as a final messages, I would say that OCT can provide information about factors that influence drug delivery and uptake, such as plaque characteristics and vessel response to devices. An adequate result of angioplasty before DCB application is key, as we have seen in all this session, and it can be assessed with OCT. Intracoronary imaging can identify different types of restenosis with potentially different responses to treatment options, and the evaluation of the restenotic tissue characteristics with imaging can be useful to guide treatment with DCB. Thank you.
Thank you for this great presentation. And the next presentation is Physiology to Guide DCB Results. It's a pleasure for me to invite Antonio Colombo on the podium.
Thank you very much, and thank you for this opportunity. I have no conflicts to disclose. So I would like to start saying that the result following lesion preparation or pre-dilatation, in my opinion, fall into three groups. Group one is good angiographic result with no or minimal dissection. This is a typical case, is a big right coronary artery. We did rotablation, high pressure balloon. You see that there is a linear dissection here, but what characterizes the benign nature of this issue is that the residual lumen. We have, as you will see, I use pressure gradient or FFR, but at the present I use much less because the angiographic residual lumen is the best predictor and really is easy, quick, and you immediately get the answer. This is a typical bad dissection. In the old time, we had to send this patient to surgery because you see that there is a dissection involving the adventitia. This is a 4 mm vessel, but the residual lumen is small. If you really don't have any stent available, you can do cutting balloon, you can do other dilatation. Many times you can convert this dissection with a good lumen and avoid, but having a stent, I think there is no reason to keep on fighting. You implant a stent and that's it. The group 3 is that when we have an intermediate result with good lumen gain with a dissection which is uncertain. We always call type B, but you know, many is like aortic regurgitation after you implant a valve, mild, minor, etc. So in this situation, we suggest evaluation of the pressure gradient. We did this in the past 3 years. I must say that recently we use less because we learned by the pressure gradient to understand which is the dissection which can be left. Our experience has been positive with no vessel occlusion when the PDPA gradient is less than 10. We still use this approach when we treat long diffuse disease and we start with the pressure wire. This is not my idea. This idea is a group of Andreas Grunzig. He published this paper, I believe, in '76. You see these no DCB, no stents. no intimal dissection, there was less angiographic restenosis if you had a dissection. But what's interesting, if you had a combination of a dissection and a low final gradient, the angiographic restenosis was very low. So the best is to have a dissection with a low final gradient. These are some examples. This is a bifurcation lesion. Our initial plan was to implant a stent in the LAD and do DCB on this big diagonal, but after pre-dilatation, we measured the pressure gradient. We started with the pressure wire. On the LAD, the PDPA was 1, and the diagonal 91, so we didn't even implant a stent on the LAD. This is a typical example where we would use, even nowadays, the pressure gradient. This is a diffusely diseased LAD. FFR is 72. We did several dilatation with cutting balloon. PDPA is 94. It's interesting that after dilatation, usually the PDPA is low, 85, 84, and you have to wait 5-10 seconds, and progressively the PDPA goes up. We didn't publish this observation, but it's really very interesting. If you wait 15 seconds, the PDPA may even reach 96 or 97. And we used 3 drug-coated balloons, and then at the end, the PDPA was 96. So, of course, you can do FFR, but we found the PDPA, if it's over 93, 94, is quicker. Or you can do other. Now it's popular to do QFR. This is a diffusely diseased LAD with a big bifurcation. We did QFR, which is obviously all red, is positive. I think it was 62. We did pre-dilatation with high-pressure balloon. You see, there are several dissections. This situation, many physicians feel uncomfortable to leave this result. We repeated QFR, and is only read as a very distal, so this is acceptable, and the 6 months angiographic follow-up is quite benign. The dissection have even healed in both projections. There's some data. We published this research letter. Now we have over 200 patients, but as I said, we use less frequently this PDPA approach because we learn how to make evaluation by angiography. But these are 104 complex lesions. You will see the characteristic later. In 83 of these lesions, after pre-dilatation, the PDPA was very acceptable, over 90, and we treated with a DCB. In 4, there was a type B dissection, relatively worrisome. In 20 lesions, the PDPA was not acceptable. We did additional dilatations, and we ended up with a focal stenting in 14 lesions, what we call hybrid approach, and in 6 lesions we had to do traditional stenting. So in complex lesions, I would say 80% of the time you can get away without a stent, and maybe in 10-15% you need some kind of stent, and in 5% you need long stent. But these are not simple lesions. You see, the one that I just showed, we did cutting balloon in 9%, rotablator in 4%, short waving 6%. Average balloon diameter was 3 millimeters, but some with big balloon. We did a lot of intravascular imaging, mainly to learn ourselves. And these are the follow-up results. We had no occlusion at 12 months, no cardiac death. We had some TLR, 5%, TLR per lesion 5%, and we had no thrombosis. So I think Bernardo showed additional data that leaving a dissection nowadays is not a big problem. So preliminary conclusions, measurement of final pressure gradient, PDPA, or other physiologic parameter like FFR, IFR, contrast FFR, which is very simple and easy, or QFR. Now many laboratories have QFR available, intended to evaluate distal flow, can be utilized to evaluate if the final result after lesion dilatation is acceptable. Appropriate and stable value of these parameters can reassure about the non-obstructive characteristic and stability of a luminal dissection. Thank you for your attention.
Thank you, Dr. Colombo. And congratulations for your excellent presentation. And finally, it's my pleasure to introduce you Dr. Renu Virmani. She has recorded her presentation to this meeting. If we can see the video.
My name is Renu Virmani, and I'm here today to present to you at the 5th meeting of the DCBs, which has been organized by Fernando. And indeed, Fernando has been a wonderful friend, and we've written many editorials together, and which has been a pleasure to work with him indeed. And today I'm going to talk on DCB, of course, and I will mention different types. And obviously, not all DCBs are created equal, and that we need to look at whether it's what drug, whether it's paclitaxel or sirolimus. And all plaques are not the same. The background of plaques is different. So I will discuss some of this with you today. Thank you so much. Today I'm going to talk to you about lessons from the pathologist's point of view, importance of the anatomic substrate in in-stent restenosis and de novo lesions for DCB. These are my disclosures. So 60 years of coronary progression. The first progress that we made in understanding and treating coronary artery disease was bypass surgery. This, in 1977, Dr. Andrea Grunzek came up with percutaneous balloon angioplasty, which became POBA, percutaneous access, opening of existing vessels. And this came into existence and became the norm for treating acute myocardial infarction even. So then came bare metal stents. Then we learned about restenosis, and this was followed by drug-eluting stents, the first generation to reduce restenosis. Then came the second generation because we had problems with the first generation. We optimized healing, and Limus drugs were shown to be more effective. Then came the cytotoxic DCBs, keeping vessel open without scaffold, stent improvement, improved thrombus, and no thrombus, or with DAP, that is dual antiplatelet therapy. Then came the bioabsorbable vascular stents, and these were leaving nothing behind. Now we are with cytostatic DCBs, that is the second generation using Limus drugs, which we think may be more effective, less toxic, and will release Limus drugs for a long time. So just as a understanding of what we learned from balloon angioplasty in the days of balloon angioplasty only without drug, we learned that it takes time for the vessel to heal, as much as 6 to 9 months following PTCA. Here I'm showing you at 14 days successful balloon angioplasty, again showing lumen enlargement. And here's some encroachment through intimal growth, but really the lumen is still open. And here, of course, we had late problems of restenosis and a very high rate of restenosis. And this was restenotic lesions were very rich in smooth muscle cells and proteoglycans. We also had the unfortunate late effects of, or early effects of thrombosis. Dissections occurred, showing you here the dissection of the media and between the media and the adventitia, and luminal thrombosis, again showing luminal thrombosis Here, the necrotic core has prolapsed into the dissected plane. And this is showing the gross examination. This is showing you necrotic core. That's the media, and that's the medial dissection right here. So if you look at native arteries, those that are rich in necrotic core, those that are poor in necrotic core, but rich in collagen. If you look at their different effects, immediately you will get a larger lumen, vessel will enlarge. However, immediately there's some, within hours, there's shrinkage of the media, and then you will get some shrinkage. Granulation tissue will start forming and gets filled, and we can get restenosis in majority of the times. Although we did have success in some cases at 28 days. This is in animal models. This is showing here in human at 6 months to 9 months. Now, if you look at the ones which are rich, native lesion is rich in collagen, you get tears in the media, you'll get neointimal proliferation shown in green, and then there's negative remodeling because of collagen laying down, and collagen shrinks and gives rise to negative remodeling and restenosis. So underlying plaque makes a difference what kind of success we're going to get or failure. Then came drug-eluting stents, bare metal stents, cipher taxes, the first generation, and we learned that endothelialization was better in bare metal stents than in drug-eluting stents. And if you look at duration being similar, you can see IEL enlargement, DES improved. They were similar. However, neointima was significantly less, and fibrin was higher in drug-eluting stents, inflammation slightly higher. So these are things we learned from drug-eluting stents and bare metal stents, the first generation. So now we're in the second generation. What are the differences between drug-eluting stent and drug-coated balloons? Drug concentration on the device is low in DES, very high in DCB. Drug transfer at the time of deployment is slow. It's rapid in DCB. Reservoir of drug is polymer. No, it is excipient is important. That retains the drug in the tissues. Drug retention in tissues short term. This is need a drug which binds to the cell membrane and is easily transferred to adjacent cells. Diffusion, good. It must be excellent in DCBs. Lipophilic, yes, even better. Much more adherent to fat. Active ingredient, not necessary. Should be active immediately because we want it to be effective. And so if you look at the release here, DCBs, it depends on design of the stent. You'll get drug release just in the area of the stented area. You can see the fluorescence green here. If you look at DCB, it's throughout the vessel wall, you can see the diffusion of the drug. And if you look at here, the percent eluted, DCB almost immediately gives up and hopefully stays in tissues, whereas in the case of drug-eluting stents, whatever they are, that is Endeavor, Zions, Nabori, Taxes, you can see that they all release drug in a slow manner and can be, most of them can be seen up to 90 days or even longer. Now, if you look at retention of paclitaxel crystals, we're first talking about paclitaxel, which was the first drug which was used on the balloons. It's a cytotoxic drug, and the retention is acting as microdeposits, reducing sustained local, inducing, say, producing sustained local drug delivery. Here you can see that crystalline material over the surface of the media, in this case, in the experimental model, which was 6 balloon inflations. You see the crystals in the thrombus area itself, adhering to the wall. Now, these are drug-coated stents, balloons, and stents that are approved by FDA. You can see the drug-coated balloon here, Impact, Lutonix, Ranger, StellarX, Sequent, Please, Passeo, and all the others. But the last two are sirolimus eluting, and this gives you the dose of the drug. You can see that the sirolimus is lower drug dose, and if you look at the paclitaxel is a higher, and highest was that in Medtronic impact stent, drug-coated balloon. This shows you the action of sirolimus, paclitaxel, and the cycle. You can see that the cytostatic drug sirolimus acts in the G1 phase of it, whereas if you look at the paclitaxel, it acts on the S, G2, and M phase. It's a cytotoxic. It kills cells, whereas cytostatic the viable cells remain viable. They don't necessarily die. They undergo apoptosis more than they undergo necrosis. So here showing the absorption and retention of paclitaxel versus sirolimus. You can see sirolimus here is in the depth. You can see depth from the lumen. It's mostly on the surface and some in the adventitia as well. If you look at overall, you look at paclitaxel, you can see that it is much more retained in the adventitia than even in intima because of its crystallinity. It can, and the drug can be passed on from the intimal surface all the way to the adventitial surface. So differences between sirolimus and paclitaxel, again, I showed you one is cytostatic sirolimus, cytotoxic paclitaxel, 10,000-fold margin of safety is only 100-fold. Therapeutic range wide, it is narrow because it is very toxic, this drug. And then anti-restenotic, yes and yes. It's a lower rate of lumen loss, late lumen loss. Anti-inflammatory, yes, no. Market acceptance, positive, mixed. And then if you look at tissue absorption, is slow and fast, and tissue retention is short, and this is long because of crystallinity. So here are some release kinetics of impact, maintaining a greater drug in tissues. You can see here Boston Scientific Ranger. You can see impact, paclitaxel, and you can see BARD. These fall fairly quickly, whereas in the stents we've shown before, they retain for a longer time. What we did, we looked at Lutonix and impact, seeing what happens at the artery wall as well as in the distal beds. So here's to show in the distal beds that we looked at. Here is showing artery wall impact, Ranger, Stellar X. They all look very similar. They're not that different. Effects on the vessel wall. Here are distal emboli. You can see in Lutonix, impact, Ranger, Stellar X. You see medial necrosis because of crystals. And then you can also see inflammation in these areas where there is paclitaxel effect. It depends on how much drug there is. Fibrinoid necrosis and inflammation. What we did was we did two different studies, and we looked at impact, Ranger, Stellar X, and you can see that in the skeletal muscle as well as in coronary band, the highest drug growth is seen in impact as compared to Ranger or Stellar X. There's much higher, although it is high in the coronary band in the Stellar X. But what I really want to show you is overall, if you look at the impact, we are getting similar results what we got in the first study as compared, this is the first study as compared to the second study. And also if you look at percent sections with vascular changes is highest in impact, but not that significantly different from Ranger and Stellar X, and the lowest is seen in Lutonix. So what about the particles release? Here what we did, we looked at the in vitro, we looked at particle release in silicone tubing, and you can see DCB was inserted from here. Guide catheter was in place. You track, balloon was inflated in the silicone tube, deflated and catheter removed, and the number of microparticles was counted, and those greater than 200 micron in size are shown here. You can see the highest is in Lutonix. The Ranger, impact, and cancers quite similar here, showing the crystalline cancers 10 to 20, impact 100 micron or so. And here you can see Lutonix, some of them 400 micron, and Ranger 150 or so. So what about sirolimus-coated stents? Or sirolimus-coated balloons. These are the challenges. They demonstrate efficient transfer and sustained tissue drug levels must be shown. Mechanism may be even more complex than required for paclitaxel. The effect of excipient and carriers needs to be closely examined. Enhanced tissue absorption, difficult to get sirolimus to enter into arterial wall within 30 to 180 seconds of balloon inflation. Hence, some kind of instant glue is required to transfer the drug from the balloon to the tissue. Extent of tissue retention, sirolimus must be continuously delivered over time, so some form of time release mechanism must be employed to maintain therapeutic levels. Here, they are showing in Salute, they have biodegradable micro reservoirs, which are made of biodegradable polymer. It's a controlled and sustained release mechanism, maintains therapeutic effects in the tissues for over a long period. Novel cell adherent technology. These are these nanoparticles house or microparticles house the sirolimus in microenvironments, releasing from the balloon delivery, adhere to the vessel wall, and a short balloon inflation time. This is to show the magic touch. Coronary PK, you can see it's high to begin with, but within 30 days is almost back to baseline. On 60 days, for sure, back to baseline. If you look at Salute, on the other hand, you can see that up to 90 days, you can see release of Salute, which is shown in green. This is sirolimus still seen up to 90 days, whereas the Salute, whereas the Zines V is even longer, and the competitor sirolimus DCBs are much lower, as shown here. So here's to show in the rabbit iliac artery, we can see these particles that are housing the sirolimus at 1 hour post PTCA in an artery wall in the rabbit artery, and here showing at 24 hours, you can see it very effectively still present. Overall, you can see at 28 days, medial injury was greater in sirolimus, smooth muscle cell was high, medial fibrin was also present at 28 days. So really, DCB design is all about balance and safety. I think our goal should be efficacy. More efficacy means less neoentima, absence of restenosis, no early or late thrombosis and biological changes, but no emboli. The goal of efficacy really is no restenosis. Safety, rapid vascular healing, good re-endothelialization, no distal emboli. Goal of safety is we have no aneurysm, no emboli. So it's a balancing act between less and more. So thank you so much for giving me this opportunity to present to you on DCBs. So in summary, what I've shown you, paclitaxel DCBs shows pathologic evidence of emboli or particulate debris in downstream vascular beds to varying degrees. There appears to be a dose-dependent effect on downstream emboli, which is more apparent for DCB coating higher dose of paclitaxel. Sirolimus-coated balloons are next technology. However, efficacy is going to be difficult to show. So far, only small number of patients have been studied, about 35 or so in each group, that is both in the periphery as well as in the coronary, and there is minimal late loss at 6 months. Clinical significance of emboli and PAD is unclear, but their significance should not be dismissed, especially in coronary beds. Most clinical trials don't take this into consideration. Thank you so much for this chance of presenting to you.
For your excellent presentations, and we have 5 minutes to discuss. So, Dr. Castrati, if you can start.
So, thank you, Anna. Let's start with the audience. If there are any burning questions for the presenters. Otherwise,
let's go through the panel.
I have a question for Dr. Cortese. Maybe one of the main concerns of many interventional cardiologists that do not perform usually DCB angioplasty is the rate of acute vessel thrombosis, acute vessel failure. You have presented a very low rate of acute occlusion. But this, do you think that in the real world this low rate is similar to the stent PCI? Do you manage this patient in a different manner after the angioplasty with a longer stay at the hospital, different antithrombotic therapy?
Yeah, this is a very important point, I think. What we have learned on when to leave a lesion after DCB safely. I will come back on this. If we do this, we will not have any cases of acute occlusion. Okay. We discussed with other colleagues recently. In my experience, I had one case of acute occlusion. It was my fault because I didn't do the orthogonal view. It was done 9 or 10 years ago, and there was a recoil. Okay, so in that case, the patient came back after 2 hours and had to put a stent. Now, there are some rules that have been already depicted in the several consensus documents. Raban later will go on this again, but if we don't have a recoil, we suggest to leave a person's stenosis maximum 30%. In my practice, I also leave some 50%, up to 50%, if the lesion is very long, very calcific, like the one that I've already shown. And if we don't have flow limiting dissection, you can be sure that you will not have problems. Sometimes you have big dissections, and you want to be sure that also the pharmacological therapy is helping you. So in this case, we suggest to use a good anticoagulation regimen for 24 hours. That's enough. We don't believe that potent antiplatelets may have a role on this, on preventing occlusion after dissection on DCB.
Okay, I have please, Fernando.
I have a question, basically was to renew, but maybe maybe Bruno can answer this question. How should we be concerned about this issue of crystal embolization? If we do DCB too long, 40 millimeter DCB on the LAD on a patient with a 30% EF, should we be concerned, or it's just an histological findings?
Bruno, this is for you.
Yeah, I mean, we see these crystals in the animal models. That's for sure. But we have to be aware that if we do angioplasty, there's so much things of the plaque which goes down. We know this from the old trials with the filter wires, and those particles are much bigger. Much more frequent than what we see with the crystalline particles of the coating, and we have to be aware that these coating particles disappear, but the plaque material does not disappear normally. So it is there, but in my opinion, it is overestimated as an issue.
Yeah.
I don't have the answer to that question, but we are making some progress. In the sense we compare the IMR in sirolimus and paclitaxel. And obviously there is an increase in IMR more with the paclitaxel. I will show later on that in a very large series of 1,600 patients, we could not see the impact of this increase of IMR on patient-oriented composite endpoint. No relationship. So some of us, Joanna for instance in Groningen, want to look at the diastolic function of the myocardium, which might be affected. But again, it will be not easy. Of course, with echo, you can look at the strain and these kind of things. So that's the kind of work that we do. But so far, we cannot find a relationship between this increase in IMR and any poaching, yeah? Especially death of.
So this is quite reassuring. My question is for Nieves, beautiful talk. My question is, with OCT, we now can identify the underlying substrate. Apart of mechanical issues, we can see the type of tissue obstructing the stent. Now, we got two technologies, drug-eluting stents and drug-coating balloons. Let's say that we want to define and to prepare a trial where we are choosing our strategies according to the type of tissue. The problem with that is the tissue is changing. It's very changing along the stent. So in some areas you will see smooth, bright neointimal proliferation. In other areas you will have calcified atherosclerosis. In other areas you will have lipid content. So if we want to guide our procedure according to the underlying substrate, what will be the methodology, the OCT methodology, to be able to say, well, this patient has got neoatherosclerosis, minimal luminaria, a larger plaque burden, whatever, and this patient is not, and then we will guide our procedures.
I think what makes the difference is the presence of calcium intrastent. So probably everything that is like soft tissue, let's say either fibrous or lipidic, could be, I mean, the easiest way would be probably put this on one box and then put in the other box calcific atherosclerosis, because this is what makes the differences and what can generally, I mean, if the idea is you're going to randomize to DCB or DS, probably the difference is that soft tissue can be probably treated very well with both. No, I will assess all the stent area, and if there is calcium at any point inside the stent, then I would say this is calcific atherosclerosis, and this is, as you know, also for calcific lesions. Sometimes the area with largest calcium is not in the MLA, so I would assess all the stent, and if there is calcium at any point in the stent, even if it's not a minimal luminal area, then I would say this is calcific atherosclerosis.
Okay, thank you. Dr. Pablo Bazas.
Just a very practical question to Prof. Castrati. We see the importance of lesion preparation, and in the consensus you show us, the general advice is to use semi-compliant balloons or non-compliant balloons as a general rule. However, in a recent Japanese consensus, the default strategy is to go straight forward with cutting or scoring balloons. I know it's very limited evidence and there are no specific trials, but what's your feeling about this strategy? Better go more aggressive with a cutting or scoring balloon, or maybe begin as the consensus with the semi-compliant balloon?
For what kind of situations you mean? For de novo? For
I know in restenosis is in general you show us some data regarding the better is to use a scoring balloon, but in other settings some consensus they claim for go independently of the setting, go straight with a more aggressive with a cutting balloon. And I don't know the rationale for that, but
so to tell the truth, we have been using the scoring or cutting balloon predominantly for in-stent restenosis, not for de novo lesions. And our preference there is other techniques, including the super high pressure balloon.
Okay, thank you.
So, thank you very much. We close here the session, and we have no break, so we continue with the next session. Thank you very much.